Thanks, Dr. Chad Smith, for talking to the op report today. A lot of surgeons very interested to talk with you and your colleagues about the events. Well, first question, about information flow. It's hard to imagine how chaotic this might have been. But when did you first realize that this situation was mass casualty?
So I was on call that night, and I got a phone call from the emergency department chief resident that was on, which is unusual. Usually we'll get a trauma page, but she called me and said that EMS had said that there would be 20 plus gunshot wounds, coming in, and so I got up and wandered downstairs and thinking, maybe there's two or three. Inevitably things are a lot of times over triage. So I wasn't expecting, obviously this. Nobody was.
Yeah. And then as they came in over the course of hours, as I understand, right?
We got initially, I want to say it was about 2:00 in the morning when she called me, and then got the trauma page that there would be multiple shootings. We got kind of a couple of different waves. The initial wave over about an hour and 15 minutes, between about 2:30, 2:45 to maybe near 4:00. Then there was kind of a lull, depending upon what Orlando Police Department was doing, and then another wave of patients about 4:45 or 5:00.
And how did you know when the final victim had come, or did you expect there might even be more all the way until noon the next day? Who knows?
Said that was, there'd be no more victims coming.
I see.
Orlando Police Department, at least that's what I remember.
I see. And it can be pretty hard just under normal circumstances, like during an elective surgery, to communicate about other patients and to contact other providers. Did you find that problematic? Communicating with your colleagues, getting more staff in, figuring out the situation?
Yeah, I just started. Yeah, sure. I don't mean to talk over you. We have a backup trauma surgeon on call all the time. So I called my backup in, and then I realized, when the patients started coming, that I would need more. So I called the next person that was closest, hoping that he would answer, and of course he did. And then I just kept calling two of my other all of my partners that were in town. And one of the we have a sister hospital, Arnold Palmer Hospital, that a pediatric surgeon on call actually called me because he had gotten the page, and I said, just please come and help.
Wow. And so tell me about the role of ER in triaging those patients. There must have been a lot of communicating between you and them while you're operating.
Well, I actually myself didn't end up going up to the operating room. I had my partners come in, my first two partners come in, and came to the emergency department, and the other ones went straight to the ICU and to the OR. And basically, once I determined that somebody needed to go, I would send them up there to them. And so I was downstairs working with emergency department physicians, triaging the patients.
Gotcha. Gotcha. How about communicating with families and loved ones? That must have been pretty chaotic. Or were you basically just functioning in emergency?
There was no communication during the event. Afterwards, the hospital coordinated with the FBI and Orlando Police Department to begin the notification process of the families.
Oh, I see. And so what was the time gap between your first awareness of the victims and when the last victims came to your emergency room?
Probably about 4 hours.
Wow.
I would say most of the victims had gotten there by 6:00 in the morning, 6:15.
I see. And I understand the weapon was a high muzzle velocity weapon. Did you see a lot of tissue destruction surrounding the bullet paths and the big exit wounds and blast effect?
Yes, absolutely.
And were you, absolutely. I suspect you're mostly practicing damage control principles?
Yeah, I mean, that's pretty much what we do with any, trauma patient that comes in. If they're, or gunshot patient, if they're hypotensive, then they're going to get a damage control laparotomy and get definitive surgery once they're corrected physiologically in the intensive care unit.
Yeah.
So that's pretty standard
stuff. Yeah. So management, you didn't have to change management because of the numbers that were coming or anything where you had to remove one patient to get another patient in or anything like that. You're able to manage patients as you normally do, in other words.
Yeah, I mean, it certainly is. It's much more somewhat chaotic environment, but it, with the extra help that we were able to call in. I mean, we usually have 2 operating rooms that can go on a Saturday night. We got up to 6 in about 45 to 50 minutes, up to the capability of staffing 6 operating rooms. So, I think we were able to handle what needed to be handled, in a timely fashion.
That's pretty remarkable, I have to say, that you've been able to sort of increase the productivity that way. How did you advise, or actually you were there in the ER? I'm just curious about your management of fluid resuscitation and blood products, not knowing perhaps whether you would have enough blood.
Well, I didn't. The thought that we might run out of blood did not enter my mind. Maybe that's good, maybe that's bad. I didn't think about it. But, the patients that were hypotensive, I tried to stratify all the patients, just kind of going around looking at their wound pattern, looking at their vital signs and their mentation. And if any of those were, bad, then I would try to get them to the trauma bay. And then other patients that were more stable were moved out of the trauma bay, and I used the trauma bay as a staging area for the operating room. And that's kind of how I separated. And I just ran around the emergency department, I don't know how many times, looking at each new patient and saying, okay, he needs to go to the operating room, and he needs to go before this person that we were going to send to the operating room because he's more or she's more unstable.
Gotcha. So circling back
just keeping that.
Mm-hmm. Mm-hmm.
Right.
And how many gunshot victims did you treat in the end?
So we had 44 patients that came that night, 9 of which died that night. 35 have lived since, and no one has died since that night.
Wow. And how many patients needed second looks or delayed definitive repairs or came back for more than one operation?
Most patients, I think there was one patient actually that had a definitive repair, with getting their abdomen closed, and the rest of them had second look laparotomies and then were, ultimately, closed. There were initially about between us orthopedics and vascular, there were about 28 cases done that first day. I think there have been over 70 now on all the different patients.
Wow. Were there any particularly interesting or surprising findings that you recall? Just the usual stuff that you see.
Yeah, it's pretty typical for this type of wound pattern. We do see these patients with these types of wounds with high-powered rifles, in events other than this, at other incidents, not infrequently nowadays.
I see. And were most of them multiply injured, had multiple gunshot wounds, or did it seem that he was there was just like one per victim, or was there no real pattern to it?
There were certainly lots of patients that had multiple wounds.
Oh, is that right?
As to the stratification, I couldn't speak to that. I don't have those numbers in front of me.
Mm-hmm. Is there any case that sort of stands out in your mind for clinical reasons or otherwise?
There are patients that yesterday I had in office, and I saw 3 different patients in the office, from this event, and they're kind of spread out amongst my partners. So there's one patient that really stands out, and she, she's getting better, and I they kind of stand out in my mind that night. There are patients that don't stand out in my mind, but she does, and she did while she was in the hospital, and now she follows up with me in the office. So she does, and just to see them kind of all of them getting better, and getting ready to go back to work or getting out of the hospital, it's good to see.
Good. So, you talked about recruiting all the additional staff. I understand you typically have two operating rooms available at night. And how many did you end up activating?
6.
Wow. And was each room with full staff, residents, circulators, everybody?
Each room was full staff. We called in more anesthesia. We have 2 anesthesiologists on call, and then we can have 4 to 6 CRNAs that were called in, and then we had circulating nurse. I mean, each room was staffed as usual, if you will.
I see. Were there any minor injuries that were triaged to other hospitals? Do you know?
There were 11 patients that went to a different hospital in the Orlando area.
Mm-hmm. And you talked about some of the subspecialty surgeons, vascular and orthopedics. Did they have to do a similar thing where they were calling in the backup to the backup? And
they did. So I called one of the vascular surgeons that also came in as well. There were a couple that came in, and then the orthopedics team came in as well. And their cases went later in the day because they were not as life-threatening as the initial torso injuries. Mm-hmm. There was a couple of vascular injuries that were treated at the time that they were taken for their abdominal or chest injuries.
I see. And did you end up overflowing your ICU capacity, or was that also ready to go?
Actually, part of the response, the medical or critical care medicine team came down and kind of started managing patients in the PACU, and then we, mobilized patients that were basically waiting on discharged in the hospital. Mobilized those patients, to a staging area. Mobilized the step-down patients that could go to the regular floor, and then got the ICU patients out. So I think at about 9 o'clock in the morning, we had something like 6 empty ICU beds, ready for whoever needed them.
Wow. And you mentioned one pediatric surgeon from another hospital. Did you have to recruit any clinical staff from anywhere else, or was it all?
There were nurses that came from our sister hospital's emergency department and operating room nurses that came that night, that came over from there to help do stuff here. Okay.
And it sounds like you really handled things pretty much by the book. Did sometimes when capacity exceeds limits and the practice protocols can sort of give way to spontaneous innovations in patient management, communication, materials. Can you think of any examples of things that you saw that hadn't been done before?
We do mass casualty drills quite frequently, and you have the tag system where there's a green patients and yellow patients and red patients and expectant black tag patients. I don't really remember seeing a lot of those tags. For me, one thing that I kind of started doing was, all of our trauma patients are DOE patients. They're given a name. It's usually a city and the month DOE, just to keep them so that their labs and stuff can be sent very rapidly before we get their name and date of birth and vital statistics or demographics. But because of that, you have Orlando DOE and Jacksonville DOE and Miami DOE, and so all those DOE names kind of run together in your head. Sure. And so what I started doing was taking a sticker from each of their sheets, sticking it to their bed, and with their so that because they fall off, or if you just set it there, it falls off. So I stuck it to their their bed. I stuck several on my sheet of paper. I've got sheets of paper from that night with just 40-something stickers, 44 stickers actually, just to keep those. And then I would try to walk around and write OR, CT scanner, stable, just one small blurb so I could remind myself of each patient and where they needed to go.
Right. So you're creating your own record-keeping system.
Yes.
So I imagine you're going to get a lot of inquiries from people who study and teach mass casualty events. Can you summarize some of the take-home lessons? It sounds like your response was very team-oriented, and sounds like you were well prepared from having gone through previous drills. Do you have an anecdote on teamwork or the volunteer spirit you found?
I think the volunteer spirit was great. I'm from Tennessee, which is the volunteer state, so um, I can't argue with that. The outpouring of support from the community, the outpouring of support from our team members coming together to take care of all these patients, at a moment's notice is amazing. We drill annually. Mass casualty incidents. Actually, the one we had in March was an active shooter event. But we do that in concert with Orange County Emergency Medical Services and several hospitals within our sister hospitals, as well as community-wide hospitals. And we there's college students that volunteer, and they get brought in as a black, tag or a red tag or a green tag, and they fly them in the helicopters and they drive them in the ambulances to really simulate that. It doesn't totally prepare you, but it gets you set on the stage, if you will, to succeed. At least some regimented plan, have some regimented plan as to where you're going to start off from, if you will.
Yeah. So devastating as this was for your whole community, it's also an event that surgeons and hospitals prepare for. And I would imagine that having an effective response as you did could be real satisfying or even career defining for a lot of people on that team. Do you have any reflections to share in that regard?
I've thought about this, and I made this comment, and people have said it back to me that it was, the best day of my career, and it's been the worst day of my career. We, especially as trauma surgeons, train for these types of things our entire careers, and knock on wood, I have a long way to go in my career. I don't ever want to experience this again, but I'm proud to have been a part of it, and I think we did I'm proud of the job that we did. I'll say that.
I'm sure. Any other aspects of your experience you want to share that would be interesting to surgeons and residents?
I would just say that doing these drills and it is cumbersome. It takes time out of your day. We're all busy, but it is really important. And I think in this instance, our practicing enabled us to, save lives.
Indeed. Good message. Thanks so much for talking to OnSurge. We look forward to, I understand you're also going to give a summary, or someone from your group's going to give a summary of your experience at the American College meeting coming up.
I believe so.
Very good. Thanks a lot, Dr. Smith.
All right. Thank you so much.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.